The oral presentation at ASCO were results of a SWOG trial, SWOG 1416, which is a randomized phase 2 trial that compared cisplatin with or without PARP inhibitor Veliparib versus placebo in patients with metastatic triple-negative breast cancer, mainly treated in first and second line of therapy for metastatic disease. In terms of background, we know that PARP inhibitors are effective for germline BRCA1 and 2 associated metastatic breast cancer. In fact, 2 PARP inhibitors are approved to treat women who have metastatic breast cancer and germline BRCA1 or 2 mutation. We also know from other cancers that PARP inhibitor efficacy might expand beyond those that have a germline BRCA1 or 2 mutation. We have data in ovarian cancer with PARP inhibitor monotherapy, and more recently, emerging data in prostate cancer. So the premise of undertaking SWOG 1416 was, can we identify a subgroup of patients with triple-negative breast cancer that are germline BRCA1 and 2 wild type, but have BRCA-like phenotype or an underlying homologous recombination deficiency, which would make these cancers more susceptible to PARP inhibitor therapy. So with that premise, the SWOG trial was designed. The trial was a randomized phase 2 trial with placebo-controlled. 335 patients were enrolled, and they were randomized to either receive placebo with cisplatin or Veliparib orally with cisplatin. And the trial was unique in a way that the primary endpoint was progression-free survival, but it was a priori decided that it would be in 3 specific subgroups of patients. The first subgroup was patients who had germline BRCA1 or 2 mutation, for whom we already have PARP inhibitors approved. And the second subgroup was those that didn't have a germline BRCA1 or 2 mutation, but had a BRCA-like phenotype based on assessment of biomarkers that were predetermined. And then the third group was negative for the previous 2, which is no germline BRCA mutation and no BRCA-like phenotype. So coming over onto results of the study, what we demonstrate that in patients who have a BRCA-like phenotype, addition of PARP inhibitor Veliparib to cisplatin chemotherapy significantly improved progression-free survival, and also shows a trend towards improvement in overall survival. Especially if you look at patients that were treated in first line of setting, there is improvement in overall survival. Whereas patients that don't have a BRCA-like phenotype, there is no additive advantage of taking Veliparib in addition to cisplatin. These results are fairly consistent with the hypothesis that we set out at the time of the trial design, that Veliparib will work in tumors that have BRCA-like phenotype, and it won't work when we use it as an addition to chemotherapy in tumors that don't have BRCA-like phenotype. And when we talk about toxicity, we didn't find any new toxicity signals with Veliparib. PARP inhibitors are known to have hematological toxicity, so the combination was associated with higher hematological toxicity compared to cisplatin with placebo, with higher rates of neutropenia, thrombocytopenia, and anemia. In terms of what these results mean for current practice and for future, obviously, this drug is currently not approved, and this doesn't change practice for us Monday morning, but it does open doors for future research. We've now demonstrated there is a pretty significant subgroup of triple-negative breast cancer which benefits from addition of PARP inhibitor to chemotherapy beyond those with germline BRCA1 or 2 mutation. This is one step towards expanding the role of PARP inhibitors in triple-negative breast cancer patients. Of course, we need to design and conduct larger phase 3 confirmatory studies in a biomarker-selected patient group.